part2, and so last week we're talking in Unit 1 about regulation, and last week we talked about the base hospital system and the regulatory system we're currently under. So we're a bit of an anomaly as health disciplines go, because we have we work under a delegation model, which is not unlike some of the provinces, but we have a very large base hospital system. We have essentially two regulatory bodies. We're regulated under the base hospital system and under the Emergency Health Services branch of the Ministry of Health. So we have two bodies that investigate and discipline and provide continuing education to some extent. EHS puts out bulletins, essentially memos about things like infectious outbreaks and PPE and so on and so forth. But base hospital, and they oversee basic life support, whereas a base hospital oversees advanced life support. And we'll talk about more about that in the next presentation. And then we have a growing number of paramedics outside of paramedic services who are unregulated. So we have a mix of regulated and unregulated in the discipline. And if you go to the Regulated Health Professions Act website, you'll see the list of regulated health professions, and it's growing. And they've got a couple that are listed as unregulated, and I think our profession should probably be listed there as well. But more about that in a minute. So let's talk about more specifically the Regulated Health Professions Act. So what is it exactly? It's so it came into effect in 1993. I'm not sure how early it came into effect in other provinces, or whether we were the first or whether we were behind other provinces. It provides a common framework for all health disciplines. Sorry, we lost internet connection there. I think we lost internet connection. We got it back here. So, can you hear me now? Okay, great. So it provides a common framework for all health disciplines, and currently, and this is a little bit different from the slides that you've got in your handouts there, I think I listed 23. There are actually 29 regulated health professions right now in Ontario, and about 220,000 health professionals who belong to the RHPA. So a pretty significant number. I think there are around close to 150,000 nurses in the province compared to about 10,000 paramedics. So what's the objective of the Regulated Health Professions Act? Its number one objective is to serve and protect the public. So that's what the base hospital does now, and that's what the Emergency Health Services branch does now. I probably should have put BH and EHSB because they both do that. And you could argue the service does that to some extent as well. But to be clear, the regulated health profession, so when you're under a college, the college's goal is not to protect the professional or the profession, it's to protect the public. But to a large extent, colleges promote the profession, educate the public about the profession, who they are and what they do, and so they serve the paramedics in that capacity. So it makes professionals accountable to the public, and I put not applicable here because nobody really knows, the general public in Ontario doesn't really know what a base hospital is or what the Emergency Health Services branch is, and there's no sort of public face to those organizations, and the public doesn't have really any mechanism for complaining. So I'll give you as an example, when I was president of the Ontario Paramedic Association, we used to get phone messages fairly regularly, say once a month or so. I guess not that often. People wanted to complain about service they received, and so I usually phoned them back and asked them a couple of questions, because in a few instances it wasn't a paramedic service at all. It was a transfer service. So I asked them, before you tell me any detail, first of all, I have to explain that we're, a voluntary organization. We're not a regulatory body for paramedics, but I want to, help you direct your concerns to the right place. And so I'd ask them, where did this happen, and were they picked up from home or picked up from the hospital, taken home or something. And usually, when they've been picked up to the hospital, taken home, I know it's a transfer service. But if they told me where it was, I could say, well, contact the paramedic service at that city, and you can just find them on the web. But people are surprised to hear that paramedics aren't self-regulated, and that there's no mechanism for either praising or criticizing or complaining about quality of care. So one of the roles of a regulated health profession, of the Regulated Health Professions Act, is to promote high quality care, and we get that under ambulance service, MOH, and base hospital under the current system. They set entry to practice standards, which is what the MOH and base hospital do for us right now. Compliance with the Act, regulations, codes, and bylaws that apply to the profession. Well, we don't really fall under the Act, so I put ambulance and MOH, but we really don't fall under that Act. We have an Ambulance Act that regulates our ambulances and sort of describes what a paramedic is, but beyond that, it's not much in the way of a regulation for the profession. The RHPA sets standards for quality of care services, and that's MOH's role. And the base hospital, just keep in mind, is a third-party agent of the Emergency Health Services branch for the Ministry of Health and Long-Term Care. Promote continuing competence of members. The role for that is BH and ambulance services. Develop codes of ethics. Base hospitals, I think, developed a code of ethics, or in the process of developing a code of ethics. Ambulance services don't really have one that I'm aware of. They define the scope of practice. So there's a scope of practice statement, and they authorize controlled acts, and they have something called a harm clause, and they also offer title protection. So as you're aware, currently we have no title protection, so anyone can technically call themselves a paramedic. In fact, the medical director for Pearson Airport has trained his firefighters in symptom relief and refers to them as paramedics. And I actually had a meeting with him and a couple of docs in the area, and to discuss this when I was Peel-based hospital program manager. And his view was, there's nobody owns the term paramedic, and I'll call my firefighters whatever I want. So as you're aware, there's changes to the ambulance acts that are coming down, and one of them will be protection of our title. When the application was made for paramedic self-regulation in Ontario, the ministry seemed to have it in their mind that as a compromise, in lieu of actual self-regulation for paramedics, maybe they would just give us title protection, and that would make us happy. And in fact, I met with MPPs, and they seemed quite pleased with themselves that they were going to change the act and give paramedics title protection. And as we explained back, that's just one small piece of what paramedics are interested in, but we'll talk about that a little bit more later. So the scope of practice is a brief description of what the profession does and the methods it uses and the purpose for doing it. Now what's interesting is I'm going to talk about the application for paramedic self-regulation in the next presentation, just to give you some insight into what we did and how we did it. But when you apply for self-regulation, one of the key questions they ask, the questions are really designed for healthcare providers in the hospital clinical setting. They really don't take into consideration healthcare providers outside of the clinical setting, because one of the questions they want to know is there anything your profession does that's already being done by other professionals? The presumption being that if if you're doing something that other professionals are doing, like nurses or physicians, why would we bother granting you self-regulation? So there was, in the formulation of those questions, there's really no understanding or appreciation of the fact that paramedics work in a completely different setting. Not just a different setting, but a completely environmentally different, which has a significant impact on how we practice as well. So, in terms of controlled acts, now we call them controlled acts in Ontario. In other provinces, they have other names for them. I'm trying to remember now. Alberta uh, is is Tanya with us? Do you remember what they're called? What they call them in Alberta?
Not offhand, right?
Yeah,
Just looking.
yeah, it might come to me later. But anyway, something similar. No, nonetheless. But each profession has its own respective professional specific acts.
Medical control procedures or protocols.
Okay. Okay. Um, maybe it's another province I'm thinking of that has a slightly different name. But anyway, the issue of controlled acts is probably the most controversial and political. And when you apply for self-regulation, it's not supposed to be political at all. It's supposed to be all about um, the public and safety of the public. And but it is very political, and a number of professions who became self-regulated, nursing as an example, dental hygiene as another, were granted, 1, 2, 3 controlled acts initially, and had to fight for additional ones in subsequent years. Dental hygiene, for example, they, I think the word might be debride teeth when they do when they remove plaque, and the dentists fought against this and won. And it took almost 10 years before the dental hygienists could get that put into um, their act, the Dental Hygiene Act, to be able to do that. And that, up until the point where it was added in, they were unable to work independently. And you'll notice now that dental hygienists may be associated with a dentist's office, or they may be working independently. They weren't able to do that before, all because of politics, really. Nursing in the same boat. So professions can have anywhere from 0 to 14 controlled acts. And that means that they are essentially able to do those acts without the authority of a physician. And now it doesn't mean that they can necessarily carry stuff in the back of in the trunk of their car and do things. I'm hearing lots of noise in the background if someone wants to mute their mic. Not sure who that is. And so these are acts that are considered potentially hazardous as part of our day-to-day activities, and should only be performed by people who are properly trained and accountable for their performance. Now, because we work under delegation model under physicians, the College of Physician Surgeons has a policy whereby it states something to the effect that if a physician is going to delegate to someone else, they must be willing, they must be willing to accept the risk, but they must also ensure that the person to whom they delegate has adequate knowledge, training, and skill to perform those controlled acts. So I'll give you an example. Most of you are going to be doing blind nasotracheal intubations. If you've got a medical director who doesn't do that, doesn't believe in it, doesn't feel comfortable with it, let's just say your medical director has never done a blind nasal intubation. She or he cannot, according to their policy, cannot delegate to you that act, because they have to be proficient in it to be able to delegate it, to be able to ensure that you're adequately have the adequate knowledge and training to do that act. Some regulated health professions perform no controlled acts. Massage therapy would be an example of that, and some, such as medicine, do as many as 13 of the 14 controlled acts. Medicine, typically 12, I think. So here are the controlled acts, and I put in the color green what I think we do as paramedics, and this is not just me. This is a group of us who put together the application for paramedic self-regulation in Ontario. And for those of you who don't know, when I was president of the Ontario Paramedic Association, we applied for self-regulation, and I'm pretty sure it's not going to happen, but it's still officially in limbo. So we haven't heard a decision from the Minister of Health, and I suspect we're not going to either. So
how long is it supposed to take?
What's that?
How long is that stuff supposed to take? It's been up for a while.
They're under no obligation to make any decision, actually. So the Health Professions Regulatory Advisory Council, HPRAC, advised the ministry against self-regulation for paramedics, quote unquote, at this time, because they felt we had sufficient regulation. So the minister is not really obligated to do, make a decision one way or the other, or announce officially whether it's going to happen or not going to happen. So at this point, it's extremely unlikely it's going to happen, and it could be another 20 or 30 years before we get a shot at it again. But we'll see. My understanding is, since the application went in and since they haven't announced one thing or another, it's possible that maybe in 5-10 years the minister at that time could say, yeah, we need to regulate paramedics under the Health Professions Regulatory Health Professions Act. So I presume that's why there's been no announcement. So the diagnosis one, I'll just tell you, this one has been quite controversial, and a lot of physicians say no, paramedics don't diagnose, nurses don't diagnose, nobody else diagnoses except physicians. But diagnosis is on a spectrum, as you well know. There's we do what we typically call a provisional diagnosis. It's a diagnosis based on the information that we have, the best information possible under the circumstances. And so we argued that we make a diagnosis because in the absence of a diagnosis, we would look at a patient and we would have to randomly select from a medical directive. We looked at an anaphylactic patient and go, well, maybe let's try some nitroglycerin on this patient. So you have to be able to come to a provisional diagnosis to be able to treat a patient. And physicians do the same thing. If a physician has a patient with a tension pneumothorax, they should be able to arrive at a provisional diagnosis based on the fact the patient is severely dyspneic and has markedly diminished or absent air entry on one side. The definitive diagnosis would be a chest x-ray, but they need to treat that patient based on a provisional diagnosis. So we argue that we do the same. Performing a procedure below the dermis, we do lots of those, including even glucometry, capillary, and IVs and injections and so on and so forth. Moving joints of the spine beyond the individual's usual range of motion. That's not us. You know who that is. Setting or casting a fracture, bone, or dislocation of a joint. Now this is an interesting one, and you could debate whether paramedics do that or not. We don't cast. But setting might be argued that we do that because we splint, and two, probably the bigger argument is we apply traction splinting, which is not a typical first aid thing. Administering a substance by injection or inhalation, we certainly do that. Putting an instrument or hand or finger beyond the external canal, no, not typically. Although you might argue tympanic temperature may be beyond the point of the nasal passages where they normally narrow. Yes, we do that. Now it's interesting, we do that with a nasotracheal intubation, of course, but we also do that with a nasopharyngeal airway. So you might even argue that an NPA is a controlled act. Beyond the larynx, we certainly do that. Beyond the opening of the urethra, no, we don't catheterize. Beyond the labia majora, this is one that we do because when we're delivering a baby, although we don't, assess for cervical dilation, we do put our hands in to get the cord out from wrapped around the head, that sort of thing, as well. Beyond the anal verge, now we don't do this now, but we used to give rectal Valium and or artificial opening of the body. We do that with tracheostomies. Applying an orderly application of a form of energy, so that would be defibrillation, cardioversion, and pacing. So even defibrillation, that's a controlled act, unless it's AED. So AED is not a controlled act, but SAED and manual defibrillation is a controlled act, which we do. 8, prescribing, dispensing drugs. So we are prescribing in the sense that we encounter a patient who is having chest pain and a candidate for nitroglycerin and aspirin. We are screening the patient to make sure there are no contraindications and no risks. And we are, in a sense, advising them that we'd like to give them the medication and getting some permission from them. MJ?
Well, we were just talking in the comments here about urinary catheterization and whether that applies or not.
Yeah, well, it certainly does for CCPs. They're trained in it. I don't know that any of the CCPs are actually doing it, but I mean,
because it's part of our NOCPs, and we're curious if that's then permitting us. Right?
I think under the NOCPs, no, well, no, it doesn't permit us. The NOCPs and our scope of practice are two different things, right? So, you know, we might talk about in this program administering TNK, but you're not going to administer TNK in Ontario. So the NOCPs and our scope of practice are two different things. And I don't think maybe urinary catheterization is part of the NOCPs. I thought it was just care of catheters.
No, it's the actual doing. Like Randy even gave us the whole how to do it.
Oh yeah, that's right. Yeah, I forgot about that. Yeah, fair enough. Yeah.
No, I'm pretty sure in Alberta that they're allowed to do it on the road at the advanced care. I'm just looking it up, but I know in the past they have been. I'm just looking it up to see if they are right now.
Would you want to? That'd be my question.
Transfer times. These guys give Lasix and they are far away from the hospital. So if they're doing that, and then they have the ability to catheterize if they need to.
Yeah, I guess.
I've had cases where the nursing home just says they can't do it, and you bring them to the hospital staff does it in less than an hour, and you're transporting it back to the nursing home.
Yeah.
You know, I don't want to do it. It would definitely save some unnecessary transport.
Yeah, perhaps, eh? Interesting.
Rob, did you see my comment?
Using.
So you know how RTs, they will use saline flush for before they deep suction somebody for the mucus plugs. Is that within our scope of practice?
So we don't generally.
So pouring some saline down the tube, basically.
We don't generally do that. I don't know that it is. I don't think anyone would have an issue if you did, but it's not our scope of practice. Quite frankly, you know, we don't deep suction that often, and whenever you deep suction, just deep suction without normal saline is probably fine. Under the circumstances we work on it. That is a controlled act. So that's an interesting one too, because going beyond the larynx, and that's exactly what deep suctioning is a controlled act, and that was not part of the PCP scope, but now it is. PCPs have been trained, at least under my base hospital, to perform deep suction.
Yeah, we got it this year too.
What's that? Under other base hospitals as well?
Oh, Adam was just saying he got it in Toronto as well. They got it.
Yeah, it's the same base hospital.
Yeah. So that's an expanded scope. So vision, eye problems, we don't deal with that. Prescribing hearing aids, we don't deal with that. Fitting and dispensing dental prosthesis, nope. Managing labor, yes. Now some of these things are interesting, right? Because a taxi driver or a husband can deliver a baby, but when we do it, it's considered a controlled act because for the simple reason that we're held to a higher standard. When I worked, you know, if you've done event medical stuff and you've dispensed Tylenol for headaches, it's the same kind of deal. Like your friend one person can hand another person Tylenol. It's not a big issue. But if you or I dispense Tylenol for headache, then we better be sure that the patient's not having a stroke. So we have to do a neuro assessment to rule out contraindications, to rule out potential adverse effects, or make sure it's the right drug for the right person in the right dose. So, just as delivering a baby, giving aspirin, giving Tylenol under circumstances outside of the regular day-to-day stuff we do is considered a controlled act. 13, allergy testing, we don't do that. And finally, 14 is psychotherapy, and we maybe do that unofficially, but not in any kind of official capacity. So the harm clause is, let me just get to this. MJ, go ahead again.
Real quick about subsequent hand or finger, number 6, and into the artificial openings of the body. I was previously told that we were not to pack wounds with the advent of this new quick clot agent, which is to be packing the wound. Are you saying that's now permissible?
Well, I'm going to be packing a wound because I don't think anyone who delivered the new BLS standards has any idea what they're talking about when it comes to wound packing. So those hemostatic dressings, the whole purpose of that hemostatic dressing is to pack the wound with it. There's not much point in putting it on the surface. Of course. Right. So I'm going to be packing a wound with that. So it is. I guess it technically falls, becomes a controlled act. So.
But they're teaching to lay people in the Stop the Bleed campaign in the States.
Right.
So what?
So they're teaching that how to pack wounds to lay people as part of the Stop the Bleed campaign. So if they're already teaching it to lay or first aiders, then it would be silly for us to not.
Well, I know that Rob was mentioning the whole duty of care and whatnot, and how there's a difference, right? Because we're to a higher standard.
Yeah, that's exactly right. So we're, the idea is we have to have a much more understanding of the implications of the things that we do. But to your point, Tanya, it's a first aid thing, understandably in the U.S. because there's so many shootings and so many, enough terrorist attacks and shootings that first aiders should be able to do all sorts of things. So the harm clause is meant to protect. Somebody's got a mic and it's really noisy. So the harm clause is meant to protect individuals from unqualified practitioners or non-regulated individuals who cause serious harm without actually performing any of the controlled acts. Title protection, sort of self-explanatory. Who's currently regulated? This is different from the slide that you have in your handout. So currently, Alberta there's been the Alberta College of Paramedics for a long, long time, and I think I may have mentioned this before, but it was a delegation system up until 2016. So it's only now have Alberta paramedics become completely self-regulated. In the past, they were still working under a physician. So they had a base hospital system, not unlike ours, only it was a single college, right? There's the Saskatchewan College of Paramedics. They are self-regulated, as is New Brunswick, as is Nova Scotia. Interesting, Nova Scotia announced they were going to be self-regulated on April the 1st. So we all thought it was going to be an April Fool's joke, but that's the date that they set. Manitoba is pending. Ontario, I'm not optimistic that Ontario is going to happen. Now, it's interesting, we applied for self-regulation and HPRAC advised against it, and it's unlikely to happen. But I'm hoping that some of the criticism we levied against the system will result in some changes. We're already seeing, changes to the Ambulance Act to that effect. Title protection is one of them. But personally, I would like to see, if you're not going to give self-regulation to paramedics in the province, then let's reduce the number of base hospitals from 8 to 1, or 8 to 2, maybe 1 air ambulance and 1 land. So 1 base hospital, and let's regulate or register every single graduating paramedic who wants to be not who wants to be registered, but if you want to work as a paramedic, you should be registered the minute you graduate from school and do your provincial exam. Because right now, graduates who don't get hired by paramedic services are not regulated, and once they're a year out of school, they can't work in any other province because they're not considered current. There are a lot of base hospital staff who would like to be registered, a lot of educators who would like to be registered. If I wasn't working ambulance shifts 5 times a month, I would want to be registered, maintain my registration, but we don't have that opportunity in this province. So that's it for just kind of a Reader's Digest overview of self-regulation under the RHPA. You guys have any questions?
Is it fair to say that most unions are against self-regulation because it's, to them, another potential oversight, another barrier for them to jump over?
Yeah, that's fair to say. I think I'll talk about this in the next presentation, but their argument against self-regulation was they were concerned that it would become another layer of scrutiny and another layer of regulation. But self-regulation would eliminate the base hospital and EHS branch's role in a regulatory capacity. There's only one regulator for a health profession, so it wouldn't add a layer. It would remove 2 layers. But I met with some union people when I did some town hall meetings, and people said to me, "Well, can you guarantee that?" Well, I'm not a politician. I'm not in the business of guaranteeing anything. Nobody can guarantee it. It is a leap of faith, but a very reasonable leap of faith, because there's no other health discipline on the planet that has more than one regulatory body. So that was the argument, and I'll come to that in the next presentation, actually, when I talk about the application process. So let me just wrap up this recording here.